Hi, I'm Marcia Frank with Idaho Public Television. Welcome back to this Dialogue Web Extra. I'm here with the two CEOs of Idaho's largest hospitals. We're talking about healthcare reform with Dr. David Pate from St. Luke's Health System and Ms. Sally Jeffcoat from Saint Alphonsus. We've got some calls still holding from the broadcast portion of the program, so let's get to those. We'll talk to Dane in Pocatello. Dane, go ahead, please.
Yes, we have an observation and a question. It would seem with the great amount of clinics sprouting around Pocatello, that with the $200 million upwards that the citizens of Bannock County have committed to, in addition to the existing facilities of the county hospital, it would look to me like there is a great amount of duplication and redundancy, which can't only be in the end, regardless of whether or not there's a public option or a total federal medical program. It would look to me like there's got to be some containment of the overhead costs in this, because I mean,
are you talking about clinics that are operated by hospitals?
No, these are clinics for imaging. I mean,
I see. Okay.
Oh, I mean, you know, MRIs. You'll find a surgical clinic,
okay.
Outpatient. But anyway, there's a lot of traditional hospital services that are being picked up by clinics, while the hospitals offer a complete medical environment.
Well, it's a good question. Hang on the line. We'll get an answer for you. This gets us into a whole interesting realm, which is physicians that have opened up their own centers. Who wants to address this issue first of duplication of services for imaging and things like that?
Well, it is challenging, and I think that the more that physicians have developed centers of their own, it has taken care out of the hospital setting, and it's challenged us financially.
Without the overhead that the hospital has.
Right. Mm-hmm. I mean, I think that, but you know, we live in a free market, and and competition is something that we believe in as Americans, and so it's something that we have to continue to respond to. And
you know, competition
let's
is
get
a good thing, but at the same time, you have a lot of people that can qualify for poverty, Medicaid, and the rest of it that are staying out of the program because they're living in houses that have been purchased and this sort of thing. And one thing we resent about this whole thing is if we do go to a facility for medical treatment, I mean, essentially, we're not we're billed up front at the going rate rather than the discount that the insurance companies offer.
Okay, this is we're getting into it. We're straying a little bit. Let's get an answer to the question about these standalone centers. Although you said you like competition, hospitals have worked very hard lobbying in this health reform bill to put a clamp down on some of these physician-owned hospitals and their ability to access federal government programs.
Right. And I would say that, first of all, the hospitals are not united on this issue. There's division in the membership of the American Hospital Association, but it is the Hospital Association's position to be against this, but it's really against the physician-owned hospitals. Mm-hmm. It hasn't been a position against the things that I think he's referring to, like imaging centers and ambulatory surgery centers. You know, I think to Sally's point, yes, it is a big challenge for hospitals because we have the obligation to take care of everyone regardless of their ability to pay, and so it can promote what we refer to as cherry picking, and that can make it harder because Sally's hospital and our hospitals have to be able to support some of the money-losing services by being able to get paying clients. So it is a challenge, but as Sally said, it's a free market, and it's a natural outsprout of the fact that the reimbursement system is broken. It's been hurting physicians, and therefore they act like normal economic actors, and they get into other kinds of business.
Thank you for your call, and I wanted to also say that hospitals have done a pretty good job of pulling physicians into your centers and making financial arrangements with them to work for you. And I guess some people question, don't those doctors have a financial interest in seeing that you, the hospital that employs them, does well? And is that kind of skirting the legal grounds there of
I think a lot of physicians today, because of the changes that we're seeing ahead, are looking to become part of a system. And there are a lot of reasons for that. Stability, being able to simplify their lives. Also, the cost of putting an electronic health record in their offices is very expensive. And so being part of a health system that has the power to do that for them is very attractive. And so I think that you're seeing a lot of that for those reasons. And certainly, you know, they want their hospital system to be healthy.
But there is a law against referring people to a hospital in which you have a financial interest. And
Right.
so is it start to get gray when doctors actually work for the hospitals? And of course they want to refer people to the hospital where they
Well,
work.
I'm not going to tell you that the federal anti-referral laws are clear, but this point is clear. There is an exception to allow this, and the reason is that actually I think Sally and I both believe the way for us to get healthcare costs down is to work with physicians. This is really the way that, certainly in my opinion, things need to go, where hospitals and physicians work together, because together we have the ability to get the costs out.
Because right now there's kind of a strange,
fragmentation,
right?
yeah.
Because physicians get paid per service,
Right.
and so they have an incentive to actually do more things, and you have an incentive to have people leave the hospital.
And one of the
earlier.
proposals that is in the bills that we're facing is bundled payments, and so that will be a challenge for physicians and hospitals, and there will have to be some organization that accepts that bundle payment and determines how that gets distributed. So that's where that's where physicians and hospitals are coming together as
Let's
well.
take a couple more calls. Leanne in Boise. Leanne, go ahead, please.
Yes, I had a question. I'm a nurse, and one of the things that I've noticed is if a participant starts to have really high medical bills, that both hospitals offer a form that the patient can fill out for financial help, charity. Now, St. Luke's form is about 6 pages and includes everything, and St. Al's form is about 3 pages and only includes the very, very basics, but not what it would take for them to actually live. What's happening is clients are getting maybe charity from, say, St. Luke's, but not St. Al's, with the very same income and
It's interesting. So we've had the email question that came in from Eleanor said the exact opposite. So this charity care seems to be confusing to people. Who gets it?
yes, and why the forms are different for
Yeah.
different hospitals.
Yeah, I can't speak to the forms. I haven't been here long enough to really investigate that. I can tell you, though, that our charity care has gone up. Our community benefit numbers have gone up. And so what really determines, I'm not sure why you'd have a 3-page versus a 6-page form. I think we'd have to look at that.
Okay.
Yeah, and I think it's just a matter of this is something that each institution does on their own, and that's why we have different forms, and probably every other hospital has a different form.
Okay, thanks for your call. I'm sorry it is confusing. Let's talk to Chris in Nampa. Chris, go ahead, please.
Hi, I want to go back to the comment the lady said about going into the ER and St. Luke's not allowing her to pay, immediately sending it on to
Collections.
collections. Yeah. I'm in the same boat with St. Luke's.
So
They
you
individually bill everything. Can you hear me?
yes.
They individually bill everything. So I have a lab done, and then another lab, and another lab. They're each individually billed, and St. Luke's won't bundle. So you call your billing, which is outsourced, and that billing person says, oh, we can send it to this company, and they're going to put them all together. You can just make one payment on all your bills. That turns out to be a collection agency that pays on one bill, pays that one off, then the next one, all the rest of your bills sit there in a collection saying you're not getting paid.
Let's try and get an answer. Obviously, you're new, you're just on the job, but you're hearing a couple comments already from people that the collections process seems to be onerous at your institution.
Yeah, obviously that's something I'd have to look into. I've never heard that before tonight, and don't know about it. But typically we do, if patients don't have an insurance or have balance due, they would be billed for. It wouldn't go right to collections. It would only go to collections if efforts to collect weren't successful. So
It sounds like
I have insurance. My insurance pays their portion. It's my portion. I get billed once, then I get told to send it out to this NCO. They'll put it with all the rest of your bills, and you can make one payment.
it sounds
And that's not what happens.
It sounds like, based on these couple of questions, that the CEO will look into it. And I appreciate your call. It sounds very frustrating. Thanks so much for taking the time to call in. I'm sure you'll look into that. Unless we've got one more call. Kelly in Pocatello. Kelly, go ahead, please. Kelly? Well, I guess Kelly is no longer there. As we wrap up, I just wanted to ask each one of you to reflect on what kinds of things have changed since you first started in this profession. I mean, you've devoted your lives to this. It's not necessarily a career that some people would want. It's very stressful, and you touch many, many lives. So reflect a little bit on why you do this job and some of the things that you think have changed that maybe you'd like to correct.
Well, I've been in healthcare now for over 30 years, and I practiced nursing for 10 years and then went into healthcare administration. I've seen some just wonderful changes over that period of time. What's really changed a lot is just the care delivery and the complexity of care, from the pharmaceutical, the medications that we deliver, the technology, the robotics that we now we're blessed with, and the care that's being delivered is the best in the world. So that complexity has really complicated the caregivers' jobs. And so as a nurse, our caregivers have so much to deal with in terms of just assessing a patient physically and emotionally and spiritually. I mean, it is, and taking care compassionately, and yet dealing with all of the complexities and the equipment that they have to be familiar with. So that's probably the biggest change. And I think the fragmentation that's occurred over the years, because our system is broken. And so what I'd like to see, and am very pleased with, is just the fact that Congress is willing to embrace this and to help us reform the system. Mm-hmm. And it is a multi-tiered approach. It can't just be insurance reform. It can't be just access. It has to include care delivery. And so I'm optimistic and also very challenged, and I wouldn't do anything different.
Dr. Bate, you come from a medical background.
Right. Well, I've had the best of both worlds. Being a practicing physician was a tremendous privilege, and then having the opportunity to lead a health system is a great privilege. I think it's hard to think of what hasn't been changing. And I think Sally mentioned a lot of things. You know, the technology is advancing at a faster rate than ever. Medications that are coming out in development faster than ever. But I think the other thing that is quite clear to me from observing it over the years is patients are getting sicker. If you look at the patient that's in a hospital today, that patient is much sicker than the patient that was in the hospital 10 years ago. Many more problems, much more complicated. And
is it sicker because we're diagnosing more things, or you really think their personal health has declined?
I think the personal health is declining, and for lots of reasons, but also we have done a better job of managing a lot of things where patients would not have survived before, and now we're taking care of patients with very chronic illnesses. We have a burgeoning population of patients with congestive heart failure. People in the past used to die very soon. Typically, it was a worse prognosis than cancer when you had heart failure. Now we're able to keep them alive longer. We've got new medications. We've even got artificial devices we can put in these patients. So it's gotten a lot more complicated. On the other end, we have had advances in what we're doing with newborns. That is unbelievable. Children that would have never survived before are able to survive, and then that's creating a lot of lifetime health challenges that we have to deal with.
And these costs, some tough decisions are going to have to be made.
Absolutely.
About, people don't want to call it rationing healthcare, but these are decisions that involve costs, and these bills are trying to look at ways to cut costs.
Right.
So,
And Marcia, I think two key things that I see, and I think you would probably agree with, is that we have to focus on prevention and wellness.
Yeah.
So we have to invest in the upfront side of healthcare. And we unfortunately focus too much on the back side, which is the acute care side. And the other is, and I've just seen marvelous things done with palliative care and hospice, end-of-life care, and to really facilitate people in their late years and as they're dying with dignity.
were you made uncomfortable by this death panel discussion?
I was. I think that that was a little over the top from my point of view. But I've personally experienced and had the privilege of being with both of my parents when they both passed away 2 years ago. And it was, I know that we can care for people better at the end of life than we do today.
Well, I want to thank both of you for taking the time to answer the additional calls and to have a little bit of a philosophical discussion about this. Welcome to Idaho.
Thank you.
And it sounds like the two of you will be talking in the future as you both are friendly competitors and collaborate on projects. So I appreciate that very much. You've been listening to Dr. David Pate from St. Luke's Health System and Miss Sally Jeffcoat from Saint Alphonsus. And this has been a Dialogue Web Extra. Thanks for tuning in. I'm Marcia Franklin.